So the last talk from me is talking about minor amputation to prevent major amputation. When I looked at the title, I just didn't know what to talk about it because apart from necrotizing fasciitis, that's the only thing which you can do. But so I thought, okay, I'm going to just modify the talk a little bit and why talk about why amputation per se is bad. My motto is not to have amputation at all. If I can save every foot. I tell my vascular surgeon, do your bit. I can save any deformity, any type of the foot, but do your bit. So don't just chop it off, because what happens when you chop it off, that's what happens. All the studies in the literature, everyone quotes amputation is good, put a prosthesis and they'll be all right. No, they don't. The reason for that is, that's a typical patient. Maybe it's a Basildon patient, but that's how they are. They're very weak upper limb, so they can't do non-weight bearing. Prosthetic change is not problem, and complicated diabetes, that means that they got a poor eyesight, kidney problems, other things. So the energy requirement goes up. Even if you do a simple Symes amputation, the energy requirement 15%, and that goes up through above knee is about 100%. And it's bilateral above knee, there's no way they're going to walk on it. So that's the reason why we want to avoid amputation. To understand the foot biomechanics, we need to understand the foot as a tripod mechanism. It works best if the equal pressure is distributed across the heel, first metatarsal, and fifth metatarsal. It had to have a 3-point contact when they're walking. And that's important. And the toes are equally important because they are essential to toe-off phase. Now, diabetics are unique in a way. They're not walking normally. They have peripheral neuropathy. So they use a broad-based gait when they're walking, and they use the toes to propel themselves forward. So if you take the toes off, that affects their mobility. If you take the big toe off, yeah, it's very easy, 10 minutes job. But then it affects their mobility. It takes 40% of the body weight, and they can't do tip of toe. But more important thing is the secondary changes that happens. Because the big toe is gone, the foot is collapsing into hind foot valgus, so developing a secondary flat foot deformity, and then there's a reduced forward push when they're walking. The little toe is similarly same. Yeah, it's not as big important as a big toe, but they still contribute to the stability when they're walking and also the toe off stage of it. And the second toe is gone. What happens is the foot will not be like this in 6 months' time. The third toe will start filling the gap, but the most important, the big toe will drift towards the third toe, so they develop a secondary hallux valgus deformity, and then they got a bunion, they got a flat foot, everything that goes along with it. So a simple toe operation can be quite detrimental. So James talked about this slide where there is a neuropathic, non-ischemic, neuroischemic and ischemic. Now, this area of the foot is, I can't do anything about it. This is unavoidable amputation if they lose the toes. However, this is where I can come in. This is almost 80% where any toe that's gone because of it or the foot that's gone is avoidable amputation. And the role of orthopedic surgeon is to prevent avoidable amputation. So aim of the talk, we talk about non-avoidable amputation, prophylactic amputations, and avoidable amputation. So non-avoidable amputation, these are the few examples. One is because of the diabetic microangiopathic to the toes. So the significant thickness of the basement membrane that happens due to hyperglycemic state that impairs the blood flow, that causes damage to the nerves and increased risk of sensory neuropathy, etc., which we talked about. That results in a dry and a wet gangrene. Then you got a severely deformed toes, which can result in osteomyelitis. Common is the second toe claw toe deformity. Often they come in with ulcer on the top of the PIP joint. Now you can say that easily, yeah, take the second toe off, but then that's where the problem happens. So treatment for this one is simply excise the ulcer, straighten the toe with a PIP fusion, put some cerament in, and that's it. It's a day case procedure. Then you got septic destruction of phalanges because the people hasn't acted quickly enough. The infection has gone too deep in and it destroys the metatarsal. Now again, you can say in this situation, we can excise the metatarsal and you can save the rest of the foot. But to be honest, that area is still fine and you can use that to join up this part. Now that sounds a bit illogical, but I'll show you in my next few slides that we can do that. And then someone has already tried it, and now but infection is not purely healed, So taking the metatarsal hair off and debridement will not treat it, and it's not adequate bone stock. This is a patient who's been referred to me last week. Now, as you can see, there's someone has already taken metatarsal off. I won't tell you it's orthopedic or vascular, it doesn't matter. But they left a lot of infection in. You got septic arthritis. So if you have to do it, then there's no way I can reconstruct that. The only way the patient will do better is a transmet amputation. So if they came to me early, probably I would have saved this foot. Then you got a patient who got so much bad deformity that the shoe won't fit. They need surgical shoes. Even then, the risk of ulceration is high. At this stage, I could advise, yes, they can lose the second toe. That's a quick operation rather than reconstruction of it. So these are avoidable, but some of the deformity can be corrected to make them better. Then you got prophylactic amputations. So this is because of deformity from previous amputation. Now, someone left with a foot like this, there's no way we can leave like that or correct any deformity. Then it's best to do transmet amputation. A good transmet amputation works very well, and they can wear normal shoes without any adaptation. Diabetic necrotizing fasciitis is very bad, and once you got it, either because of dry gangrene or wet gangrene, it spreads very quickly. This is the one of the emergencies in diabetes. That's where it doesn't matter what James said, whether they're a foot surgeon, a hip surgeon, a hand surgeon, everyone can still do an incision drainage. This patient just needs an incision drainage across the tissue planes and release the pus and antibiotics. Everything else, we can do that at a later stage. And this is what happens if you don't treat it, because the infection, although it also could be there, but the infection can spread across the tendon sheath. And that's the reason why you have to open up not only the area where you got infection, but across the tendon sheath, because the tendon sheaths are considered as a highway to infection, both in the foot or across the ankle. This is an example. This is borrowed from King's, where they got a patient with an infection and ended up debriding so much of it. So again, a slide from Venu where they done a simple debridement, but as you can see, there's so much of it involved, and you have to extend. So simple debridement of the ulcer alone, most of the time, will not help you. So this follows best with this paper published by King's Group, where they talk about a traffic light system of where the ulcer is, tissue which is partly involved, and the green tissue. And when you do debridement, you have to go up to the green levels. That amount of debridement you have to do. A simple microscopic debridement, a small area will not help. So this is ulcer, this is from the paper, where this is the area of the red and green, and that's the amount of debridement they end up doing it. Lastly, avoidable amputation. This, as I mentioned, this is where we come in. Now, the avoidable amputation is because of the ulcer that happens in the toes as a result of either transfer lesion or a pressure from ulcer which was treated before by amputation. So first of them is a transfer lesion. We talked about this slide before, where the patient had a third toe taken off, the fourth toe got involved. And this is a common, this is what James was showing a paper of, one of the example, where the ulcer is on the lateral side because the patient is walking with significant varus and adductor deformity. So as a combination of tightness of tibialis posterior and tibialis anterior, and someone has taken off the fifth, fourth, and third, but ulcer do not go away because the deformity is not treated. That's where in this patient you need a two-stage procedure. You can argue the patient has only two toes. He didn't want amputation, he wants something done, so I did what I thought was right. And he got a plantigrade foot, but only two toes. He went on to walk on it until he died. Then he got cloto deformity. We talked about this because the hind foot equinus and the cloto deformity, and the Bassett done two-stage treatment, so I'll skip this part. Principles of foot salvage would be to surgically offload I think I mentioned this top, so I'll skip this one as well. Surgical offloading. Okay, this is where I was talking about that even if you got an infective destruction of the bone, there's no point taking the ray amputation for this part, purely because that affects the stability of the foot and the way they walk. So what I do, I coined this G technique because this is just I picked up a word. So what I do this one is I excise the bone here, take a plastic sheath of a 5 ml syringe, cut into the shape of the C and measure it to the gap that's left in where the bone has been removed and fill with cerament V. Cerament V purely because, nothing to do with the microbiology, purely because cerament V hardens to become like a Palakoff cement, hard. I drill into the bone, inject cerament V first, stabilize with a K-wire, and leave the cerament V around the plastic sheath of the syringe. After 15 minutes, when the cerament V has set, take the plastic sheath off. Because I now reduce the tension on the skin, I can primarily close the skin as well. So what patient left with is a block of cerament V and a wire. Yes, the cerament V gradually elutes away, and that left with a small toe and an intact metatarsal. Now you can say the toe is not functional. It does not matter. The toe becomes stiff in diabetics when you touch it. And that stiff toe is fine. That gives you stability. So without losing the toe, we maintain the stability of the foot. So that we can do not only the small toe, we can do for big toe as well. Considered as a muscular technique, but it's not true muscular. Next, talk about heel ulcer. We didn't talk too much about the heel ulcer. This is a very difficult problem, anyone with a heel ulcer. It could be either pressure ulcer or because of the vascular cause of it. So what I do in this patient is, obviously we need MR scan to assess the degree of osteomyelitis. Based on that, we do a partial calcaneectomy, and we do something called silo technique. I don't know whether you heard the word silo, where we drill multiple holes with a 2.5 drill, and using a syringe, inject cerament G in this area. Cerament G is liquid, almost until 3 minutes, so you got plenty of time to inject inside. In the cancellous bone of calcaneum, everything is interconnected. So if you inject into one hole, it will come out with the other hole. That's the silo technique. But soft tissue cover is very important. This is where the papers fail to talk about it. Yes, silo technique heals the osteomyelitis, but it does not heal the ulcer. The previous talk, we talked about the plastic surgical medial plantar artery flap. Because I don't have plastic surgeon, and so I learned how to do it. So this is my take on medial plantar artery flap. But you need to have a vascular CT angiogram to show whether the vascular medial artery is intact. So this is how I do it. So basically, sorry, go back again. I take a flap across it, shift it across, cover the wound, and this is synthetic skin graft of BTM stitched across it. And this is the patient after a couple of weeks. Yeah, it does work. Not every time, but it does work. So lastly, we talk about a few case examples. We talked about the unsalvageable type of feet. As long as the vascularity is intact, my take on it, we can salvage it. We can see this metatarsal head is shifted down purely because the second and third metatarsals are gone, so the ulcer is there. So I can take the fourth off, and I can make this heal. The problem is the fifth will take the pressure, and the same problem can happen. So I just simply curated that, filled with cerament, offloaded that. I didn't do anything to the skin. This is quite early on. I think this is around 3 years back now. So I just debrided the skin and left it, and this is 2 months down the line. Now he has a shockward foot the other side, where I reconstructed, so I've been seeing him the last 3 years. This remains fully healed by now. So he wears normal shoes on this side. This is another ulcer. This happened because this patient went on a long holiday where he had to walk quite a lot, and he developed an ulcer under the first metatarsal head. This is because this patient has a flat foot type of thing, where the hind foot was in valgus, and that causing a lot of pressure in the front of the foot because of pronation. So I corrected the hind foot alignment with a calcaneal osteotomy, and then local debridement and fill synthetic skin graft. This is a clinical photograph at 2 months' time. So we don't need plastic surgery for every diabetic foot. This is just offloading again. This is where I'm coming to, where you got a significant infection and a deformity. Now, you can say this patient would require amputation of the big toe because he got infection, as the photograph don't show it, but he got ulcer here, and MR scan show he got osteomyelitis at the MTP joint. So what I did in this case is taken down the joint, curated the canal, filled with cement, and stabilized the MTPJ with 2 wires. So doing an essential MTPJ fusion, but 2 wires, but I bury them. This is a day case procedure and the patient walks on them. The reason for burying them is because I don't know when to remove, because we're not expecting to fuse. I want some fibrous union, and it might happen in 8 weeks, it could happen 3 months' time. But there's no point to removing the wires just because we had to remove them at 6 weeks. So if you bury them, they will find itself out and sometime become loose and they'll come out. But it'll leave with the toe, which is slightly floppy, but in a slightly better position, and the infection would have healed by this stage. So that's the whole principle of that. Lastly, Hemant mentioned about that courses I do. I do a lot of diabetic cadaveric courses. This one I'm doing for the vascular only. This is this Monday coming on the 14th. It's purely aimed for vascular surgeons. I do for orthopedic surgeon. We've done 3 courses so far. This flyer is for the last one, which I did in 2024 in Cambridge. The next one this year will be in December 25. We haven't come to details yet. After I've done the vascular one, then we start promoting the orthopedic one. So look out for it. If you want to learn a little bit on cadavers, we can teach you in 2.5 days in December. Thank you.
Fantastic, thank you very much. Any questions on that bit from the audience before we you want to go ahead?
Yeah, just a quick one at the end there. With the infected hallux valgus that you leave in fibrous non-union, would you then wait for it to heal and subsequently fuse it, or just leave it in that slightly floppy state at the end?
To be honest, these patients are not concerned about the hallux valgus deformity as such. They came to me because of the ulcer they got. And after a few weeks' time, the ulcer has healed and the wires have come out and it's touch floppy. But the deformity is healed, ulcer healed. Right. So answer to your question is no, I won't do it. But if they come, I won't be hesitant to do it if the infection is healed.
And any others there? I was interested in seeing your slide on the G technique.
Oh, yes.
So I've tried it a few times and been very depressed by it. But I think maybe because I was using Cerebral G, it just seems to disappear off and leave me with a more floppy toe. But
that's the reason why I said it's a type of mascule, because as part of mascule, you have to go back into put some bone graft in. And my idea would be that to take a small fibular graft and plug it in the place. But none of the patient wanted after that, because the toe has healed, they got stable foot, and I said, why you want to do that? And I'm a bit hesitant at this stage because the vascular has shrunk to the stage. If I do any lengthening, it might cause any vascular issue. So never done this. So it's not truly a mascule, but it's the same principle.